Hello from Boston. Today we're with Dr. Dale Adler, who is Professor of Medicine at Harvard Medical School and Executive Vice Chair, Department of Medicine at Brigham and Women's Hospital in Boston. Dr. Adler received his MD at Weill Medical College at Cornell University. He did his residency in internal medicine and fellowship in cardiovascular medicine at Brigham and Women's Hospital in Boston. Dr. Adler's clinical and research interests are in cardiovascular disease, specifically complex coronary artery disease, diabetic heart disease and its prevention, and valvular heart disease. Dr. Adler also has extensive experience in managing healthcare organizations and integrating hospital networks. Dr. Adler, thank you and welcome.
Thank you very much for having me.
Let's start with valvular heart disease. My mother had mitral valve repair at Brigham and Women's Hospital several years ago, so from a patient perspective, I learned just how intricate and how well timed and choreographed the whole process of managing valvular heart disease has to be in order to benefit fully the patient. But not everyone needs the surgery right away. So what is the role for medical cardiovascular treatment in valvular heart disease, and how it's best to prepare people for surgery and manage them in postoperative period from a cardiovascular standpoint?
You're asking a very interesting question in the entire realm of cardiology. And if we talk about mitral valve repair, you have to realize, and I'm sure you do, that 2.5% of males and 6.5% of females in this country have mitral valve prolapse. And in fact, if you examine people, and this was done many years ago with young people coming into college, and people did a careful listen, and they said, my goodness, 15% of these people have a mitral valve click. Now, there's 15% who have a click, but like we said, the numbers, 6.5% in women, 2.5% in men, are much lower for who actually has real mitral valve prolapse. But the real numbers are that out of all those people, 90% of them will do perfectly fine throughout their lifespan. And it's really only 10% of those people, so it's becoming a progressively smaller number, who actually will really need attention to their valve. And so whenever we meet patients, take a good listen, realize they have mitral regurgitation, they have an echocardiogram, you find out, yeah, they have what we call classic mitral valve prolapse. The leaflets are thickened and there's some amount of prolapse. The leaflets open perfectly, they move from exactly where they're supposed to be, open up nicely, but when it's time for them to close, one or both of the leaflets will bow backwards into the top chamber of the heart on the left side, and there'll be a leak. Most of those people aren't going to need anything done over a long period of time. And so the group you're interested in always is the group that's symptomatic. Of course, if somebody says they're short of breath, or if they're fatigued, struggling, we're interested in them. Or if they have a leak that's severe enough so that over time we're realizing that their heart chambers are enlarging. And along with the enlargement can sometimes come an increase in the pressure in the lungs, and sometimes when they stretch the top chamber of their heart on the left side, they could start to have rhythm disturbances. So that's really the group we're interested in. Now, your question, how can you prevent that? Are there medical solutions? Probably one of the most important lessons we've learned over many years is that if that process is going on, so the leaflets are prolapsing more, they are having a harder time keeping the blood moving forward, the chambers are starting to stretch, then it's a mistake to try to use medicine to manage the people. So we could use diuretics, we could make the heart a little smaller, we could use ACE inhibitors, unloading agents, make it a little easier to allow the heart to pump the blood forward, and a person might feel better. But even though they'll feel better, that underlying process with the heart stretching, getting worse, will still be going on. And it's been shown very nicely that if you are doing that, if you're treating a bad valvular disease medically, you're not doing the person any favor at all. Eventually, they just get worse and worse.
So in other words, if there is a mechanical problem in the heart that's been identified and there is evidence, presumably by echocardiography, that it's getting worse, as well as by the clinical examinations, the most important thing is to focus on treating the mechanical problem, and then only after that to give a medical support to the heart.
Correct. And one caveat, one area to be careful. So you can have somebody who has what seems like very severe mitral regurgitation. They feel very well, and their heart isn't stretching. And it always is very nerve-wracking to say, oh my goodness, there's a severe leak. They feel fine, their heart isn't stretching, the pressures in their heart are good. Shouldn't we correct it? And there's a lot of discussion, and in this country, when people write guidelines, what they say is, well, if it's a severe leak, even though a person feels fine, even though the heart isn't stretching, if you're very sure you could repair that valve and repair it very safely, then it's okay. It's okay to go ahead and consider repairing it. And I think we just have to be very cautious with that approach. So with what you said, I would just add, in addition to the severe mechanical problem, something else that shows you the way the heart is integrating it. If the heart is integrating it in a way that tells you the heart is suffering, then absolutely it's a mechanical solution. Don't try to use medications for it.